Hi, everyone. Welcome to the Clinical Corner, which is a podcast YouTube channel for general practitioners from South Asia. Dr. Hina Jawaid and I, we have discussed and thought that there is a need of a podcast for our South Asian general practitioners. A little introduction about myself. My name is Dr. Tehzeeb Zulfiqar, and I am a doctor from Pakistan. I'm right now based in Canberra, and I am not working as a GP. I'm working as a research fellow here. My background is that I was working as assistant professor and then elevated to associate professor in Pakistan at the same institute where Dr. Hina Jawaid is right now, an associate professor of family medicine. So I was also involved in that initiating the diploma of family medicine for Pakistani general practitioners. So I'm going to now introduce ask Dr. Hina Jawaid to introduce herself and give us a bit of a background, and then we are going to go with the podcast. So before give ask Dr. Hina Jawaid, these podcasts are basically planned for half an hour duration, and they will be uploaded fortnightly. We haven't decided yet about the frequency, but fortnightly is what has been suggested to us. So off to you, Dr. Hina. Now please introduce yourself, and then we'll embark on the podcast.
Thank you very much. Assalamu alaikum and good morning and hello, everybody. My name is Dr. Hina Jawaid. I work as a consultant family physician, and I'm also an academic based at Health Services Academy, Islamabad, where I work as an associate professor and head of department in family medicine. I'm also heavily involved with WONCA, which is Global Family Doctor Organization. I'm currently regional chair of the Women Working Party and chair for a working party for research South Asia. So I get a chance to interact with family physicians across the world. So that's my introduction. Yeah.
So, Dr. Hina, I've been following you on your various activities with WONCA, South Asia, and other conferences also, where you've been extremely busy and instrumental in raising voice about different uh, problems, which are population-related problems. So what we're going to talk about today is the World Population Day, which we just had in July. So I was just wondering if you can give us some idea of what is the current population in South Asia, and what are the common issues related to population in South Asia.
Sure. The world population is around 8.2 billion, whereas South Asian is 25% of it. Pakistan's population is 235 million at the moment and increasing rapidly. Pakistan is currently the fifth most populous country. And as you said, we recently had a World Population Day, and it has been linked to various projects improving the health in various sectors, and use of family planning methods or contraceptive methods is one of them. There are a number of projects running in the country at the moment, and I'm sure in other countries of South Asia. So, so the work is taking place at the moment. Yeah.
All right. So, Dr. Hina, as the South Asia as a region, with which you said is have about one-fourth of the world population. So, what do you think are the main factors that we have such a high population?
I think there are a number of factors relating to the population, how we can control it, and how we can best provide the facilities to the existing population. A number of factors, for instance, literacy rate in the country, access to medical facilities, including family planning methods, awareness of the population, the cultural in regions it's a culturally sensitive issue to talk about, so it's not openly talked about. And I think all these factors are exacerbated by lack of a robust, functioning primary care health system within the country. We need more qualified and trained primary care physicians within the community in order to get a lot of burden of disease reduced, along with improving family planning methods.
So when we were discussing before this podcast, you mentioned something about the population, the high population related to Human Development Index also. So can you elaborate a bit more about Human Development Index and how that may be related to the high population rates in South Asia?
Sure. Human Development Index, in simple terms, is calculated based on the population's life expectancy, their education, and their per capita income. And if you look at the global the figures, South Asia has one of the lowest Human Development Index, and Pakistan has got a lower index. It's sitting at 0.5 at the moment.
Mhm.
Now, what does this mean? This means that whenever there is more population, um, then there will be health-related issues as well, because there's more demand for medical supplies, for the food, for the clothing, the day-to-day living, and the expenses and the transportation. It also has impact on the number of times a woman is getting pregnant, which is a vulnerable state. She needs a certain type of nutritional intake, foods for the growth of the baby and to look after her own health. Anemia is very common in South Asian countries. And similarly, if the mother's health is compromised, she's going to produce a baby whose health is going to be compromised. And I think that is one of the reasons why the maternal mortality and the infant mortality rates are quite high in this part of the world. So probably because of the disparity, we are not able to do justice to the vulnerable groups, the mother and the child.
Thank you, Dr. Hina. So I was reading somewhere that the world population will double, I think, around 2050. The South Asian population would double in the next less than, I mean, I think around less than 30 years. So it is going to double. What do you think? What should we do to control this population?
Okay. Well, one of the things, and I'm going to talk in relation to the World Population Day, which is we have already celebrated on the 11th, and as I mentioned, there are a number of projects running on the family planning front. So I think one of the methods would be to increase the uptake of contraception among the population, which is called contraception prevalence rate, or CPR. The aim is to increase it worldwide. But in those parts of the world where it's already low and sitting at a low percentage for a number of years, for instance, if you take up studies from 2014, about 10 years ago, the prevalence rate was roughly in the mid-30s, 33 to 35%, and it's currently almost the same, despite advances in so many things, and the level of awareness hasn't increased.
So, what could be the reason that the level of awareness is not increased? I mean, is there anything that the government can do, or is there anything that the general practitioners can do? What do you think? Where is the problem that the awareness is not increased?
I think access to the family planning information, the
Mm-hmm.
services, and the products or the supplies, that is important. And the access has to be voluntary, not something which is forced. And you can only ensure voluntary access if the population is aware. And I'm talking about a range of age groups. So whenever a female starts her puberty, there's onset of period, so she's sexually active or in the reproductive age. So from 12 to 15 years onwards, up until when she develops the menopause. So that population, that cohort needs to be focused on, and this age group needs to be aware of. And I think equity, health equity is also important. We have to ensure the people who are the poorest and most vulnerable in those areas where there is lack of healthcare facilities, for instance. We ensure that the medical supplies reach these people. And as I mentioned earlier, having a robust primary care, there's no alternative to it. If you have a qualified, trained family practitioner, a family physician in your community, then that is an asset for that entire population. So I cannot stress more on the need of having a trained family physician.
So, what do you think about the supply and demand of contraceptives when we're talking about that? So, do you think there is sufficient supply of contraceptives, but there is not much demand, or there is the demand is there, but the supply is not there? What could be the main uh, area that you think is an issue when we're talking about the access and awareness of contraceptives?
One of our studies last year showed that the study population, how they come to know about a type of contraception is through the relative. Very few people even mentioned or selected lady health worker from the list of options. And even less number of people mentioned a doctor or a general practitioner. So I think because there is not only the population, there is awareness needs to be given at the lady health worker, the healthcare professional level as well. There should be regular updates, CMEs of the doctors, particularly those who are based in low socioeconomic setting, particularly primary care physicians. And I believe once the awareness is there, people will start talking about it, asking about it, the demand will increase. The demand does exist.
Mhm,
Uh, However, because the end user is not aware of it,
mhm,
or including the different types of contraceptives that are there, they're not even aware of the different types of contraceptives,
mhm.
how to take them, what are the precautions, which people should avoid in certain medical conditions if they have to avoid, and regular monitoring for that purpose. And yes, availability, because women may not be able to talk about them openly. So they need to be encouraged through programs which include door-to-door visit of lady health worker, probably giving them information leaflet in their own language. A number of people are able to read Urdu language, which is a local language. So probably with diagrams, pictorials, there is information leaflet that is provided onto them. Yeah.
Right. So, just for the audience, lady health workers are a workforce which is specific in Pakistan, and they're at the community level. These women, they do not prescribe contraceptives, but they are very active in spreading the knowledge, identifying women who need contraceptives. So, Dr. Hina, what are the different type of contraceptives that are available to the South Asian population in general and in Pakistan in particular?
Okay. Well, I'll go through the list of the different types of contraceptives which are available. There are a number of types. Their availability depends on the area where you're based. There's more availability in urban areas compared to rural, where the options are less for the end user or the population. The most common type used are barrier methods, which are external condoms used by males. And one of the reasons why they are used most, because they are easily available. A number of people are aware of it. They feel it's safe to use because it's something that they are not consuming inside the body. They're not taking it orally, or it's not something which is going inside the body. It's external use. So side effects are less. And the level of awareness, as I said, is more about barrier methods. And one of the advantages is it gives you protection against sexually transmitted infections.
Okay.
Uh, there are other type of contraceptives, and the other commonly type used are the pills,
Mm-hmm.
which are tablets. They are
Mm-hmm.
called oral contraceptive pills. And there are two different types of pill. One is a combined pill, which contains two hormones, estrogen and progesterone.
Mm-hmm.
And then there is a progesterone only pill. I was taking a session about a couple of days ago they were all educated people from different backgrounds. Some were lady health workers as well. But it was a bit surprising for me to know that most of them knew about the pill, but they didn't know that there were two different types of pills existing, and they were not clear about what is meant by combined pills. So maybe it's always good to understand what the audience knowledge is first, and then you top up their knowledge and fill in the gaps. The other common types include injections, which you get every after 12 to 14 weeks. Then there are devices which are placed within the uterus. There are implants which go under your skin. It sits in the skin in your arm. And these are long-term reversible contraceptives. Then there's something called emergency contraception, in which you have the option of a tablet or having a small device placed within the uterus. And then the permanent methods of contraception are available for both men and women. For men, it's called vasectomy, where you kind of divide the tubes. And in females, similar procedure, which is called a tubal ligation. So these are permanent methods. In places, there are certain type of surgical procedures where it can be reversed, but obviously the reversal rate, there can be a fertility failure. It's not 100% thing. There's no reassurance, and they are almost classed as permanent methods of contraception.
So in Pakistan, do they use that patch, which is quite commonly used here?
Yes, combined oral contraceptive patch, the transdermal patches are available, but they are very costly and it's not available for the majority of population, which may not be able to afford it.
So the contraceptives that are available in Pakistan, the ones that the range of the contraceptive that you just described, are they available free of cost, or there is some cost associated with these?
In some of the NGOs and some of the organizations provide free of cost, but that amount isn't sufficient to cover even the entire population of that area. Condoms are usually given free of cost, particularly to the vulnerable or high-risk populations. But again, that this is something which is not done on a regular basis. We do need consistency in family planning services, but we do see a lot of gaps in the provision of the service. Yeah.
Thank you, Dr. Hina. So another question is, so when someone comes to you and you think that this woman or this family, they need to practice contraception, or they ask you for contraceptives, what type of checks or questions are there that you will ask them as a general practitioner?
Okay. So for instance, we talk about the pill. For the pill, which is a combined pill which contains estrogen and progesterone, there are certain things we need to check. First, we have to explain the woman how it works, so what's its mechanism of action, when she can start taking it. And before she starts it, we ensure she's not pregnant. We do a urine pregnancy test. We check blood pressure and weight, and then we ask them any medical conditions that they have. For instance, do they smoke? Do they have a high blood pressure or diabetes, migraine headache? And then if there is any history of things like cancers in the family, for instance, breast cancer, cancer, ovarian cancer, if they ever had any clots in the leg, because then the risk of having these side effects, the clotting of the leg, can be increased because of the estrogen component. If they are already taking medications like treatment of hepatitis, tuberculosis, epilepsy, then because the anti-epileptics or anti-tuberculous drugs, some of them, they affect the enzymes in the liver, and it affects the overall effectiveness of the oral contraceptive pill. So
Mhm.
there's usually a checklist which can be easily available, and you have to go through those questions. Age, if any woman is 35 and above, and
Mhm.
if she has more risk factors, like if the weight is an issue, if she's, say, somebody who weighs 90 kilograms or more, and if she has got a history of a clot in the leg, or she's a smoker, then we advise not to use the combined oral contraceptive, because there are safer options available. Now, by safer option, I mean the progesterone only pill is there if she still wants to take the tablet. Then we have implants, we have in the womb devices which goes in the uterus. We've got injections as well. So it's always worth offering them a safer alternative if you feel she's high risk for the combined pill.
So there is one thing, another thing with these combined pills, which is the people do gain a lot of weight. So these days, girls are and women are very conscious of those. So you have excluded that in your screening that the woman doesn't have high weight. But then, what if the woman comes to you and say that I'm gaining weight? Do you have any? What do you do at that time?
Okay. Um, the studies have shown that combined oral contraceptives do not have a huge impact on your weight.
Mhm.
But I understand the patient's perspective, and sometimes there are myths associated. Now, if somebody is already weighing on the higher side of the scales, as I said, 90 kilograms and above, then we try and avoid them, avoid prescribing combined pill. But if somebody isn't, what we do is we give them a short period, say a trial for 3 cycles or 3 months. So if the contraceptive packs that come for the combined pill, they usually contain supply for 3 months anyway. So we offer them the pill and we check their weight before, and then we ask them to come after 3 months. If they feel that the weight is increasing, there is no other cause of weight gain, and there is no other medical condition contributing to the weight gain, and they are pretty sure it's the pill, then obviously we offer them an alternative. But what I'm trying to say is that combined oral contraceptive is a good option.
Okay.
It has low range of both the hormones estrogen and progesterone.
Yeah.
It has a good safety profile. And
Okay.
if somebody hasn't got the risk factors in them and they can be used, then considering it causing weight may not be the option to just lose the combined oral contraceptive pill option, um, because the studies haven't proven that it tends
Okay,
to.
so the evidence says that it's not related to the combined oral pills.
Yeah.
Another thing, Dr. Hina, we just had the World Fibroid Day also. So do you think that oral contraceptives or the contraceptives contribute to fibroids? Because that's one of the another thing that is at the back of a lot of women who come for contraceptives, that it may increase, it may result in fibroids.
Well, again, the combined pill or the progesterone only pill, they do not lead to development of a fibroid. But if you already have a fibroid,
Mm-hmm.
it may not reduce the size of it,
Okay.
but some researchers believe that it may increase the size of it.
Mm-hmm.
But again, it's something that you have to discuss. So I'm assuming a female who comes in and says, I've got a fibroid, they usually have an ultrasound with them, and it does give you the measurements.
Okay.
There is no absolute contraindication to the use of combined oral contraceptive. Again, this cohort can be given a trial. And if for some reason there is no impact on the bleeding, or they feel the pain in the lower tummy pelvic area is increasing and they are in distress because of it, then obviously it can be stopped. But again, there is no kind of a definitive study or an evidence linking the two together.
Yeah. Thank you for that, Dr. Hina. And I'm aware that some women who are on contraceptives, oral contraceptives, in fact, they have the reduced menstrual bleeding also.
Yeah.
So, that may be with fibroids, that may be the same phenomena?
Yeah, I mean, for heavy bleeding, menorrhagia in the medical term, for the gold standard treatment is having an intrauterine device. And
Okay.
if it's due to the fibroids, there are other hormones, there are other treatment options, the non-hormonal treatments like tranexamic acid and mefenamic acid.
Mhm.
And then people can use combined oral contraceptives as well to control the amount of bleeding, because bleeding becomes less with a combined pill. And then surgical options are there, and then ablations are there as well, which you can discuss with the gynecologist.
Okay.
Uh, but combined oral contraceptive pills can be used to control bleeding, but for menorrhagia, the gold standard is having a intrauterine
And
device.
and for that, the woman has to, you refer the woman to the
Yes.
gynecologist, right? Okay, thank you. So we've been talking about pills. So what should a woman do if she misses a pill?
Okay. If she misses one pill, so okay, we are talking about the combined pill.
Yes.
If she misses one pill, then she needs to take it as soon as she remembers it, ideally within that 24-hour period. If she does that, there is no need of additional precaution. So she doesn't need an extra precaution in the form of another a contraceptive like a condom to prevent a pregnancy. If she misses two pills, then she needs additional precaution. So if a woman misses two pills, so she takes the pill of the day that has gone and of that day as well. Well, that's a missed pill. But if she's on the day three and if she has missed two pills, then
Mm-hmm.
she takes the pills as soon as she remember. But then she needs an additional precaution for the next 7 days. Okay.
Okay.
Yeah. Uh, and depending if she has an unprotected sexual intercourse at a certain time in the cycle, then she may need an emergency contraception as well.
Okay.
Yeah.
So we will come to emergency contraceptives in a little while, but the what you're talking about, the missed pill, and what is she going to do about it? This is only for combined oral pill. What about the progesterone only, or is it the same?
Okay, with the progesterone only pill, there are two types available. One of them has a window of a 3 hour only. So
Okay.
you have to take that pill religiously. Say, for instance, if you take pill 8 in the morning, you have to take the pill at 8 in the morning regularly.
Okay.
And if you miss a pill, you take it within the 3 hour window.
Mm-hmm.
So before midday, if you take it and you are within the 3 hour window, you don't need the additional precaution.
Mm-hmm.
Some type of progesterone only pill, you have a window of 12 hours. So if you have missed the pill at 8 in the morning, you can take it till 8 p.m. in the evening. Yeah.
Okay.
If you miss the pill, one pill, then you take it as soon as you remember along with that day's pill. So you end up taking two pills in a day. But if you've done it more than that, then you need an additional precaution for again 7 days and an emergency contraception if you had an unprotected intercourse in certain days. So in the first one, day 1 to 7, which is the day when you're having the period, and after the ovulation, you need like from day 15 to day 21. If you had an unprotected intercourse, you need an emergency precaution. I understand this is a lot of information, but this is something which needs to be understood by the patient in order whether they qualify for an emergency contraception or not. And if they don't know, they can always come to see the doctor and take advice.
So you ask all these questions when you find out that the patient has missed the
Somebody's
pill, and
taking
then
it.
you ask all these questions.
Mm.
What about IUCDs? So do you use the intrauterine contraceptive devices? Do the general practitioners, are they mandated to do intrauterine contraceptive devices, or that for that you refer them to the gynecologist?
Well, if the qualified GP or the family physician is trained to
Okay.
insert the intrauterine contraceptive devices, they
Mhm.
can do it.
Okay.
But if they feel they do not have the training and they do not have the skill to do it, then obviously they refer.
Okay.
Uh, a lot of family planning centers within the public and private sector domains have qualified staff.
Mhm.
Uh, they can be lady health worker, they can be a nurse practitioner, and they can be doctors. So
Mhm.
whoever has the skill and has done the training to insert it, they do it. Um, the these trainings have to be updated after a certain number of years, say
Mhm.
after about 4 years or 5 years. So you go through another up-to-date course. Because sometimes devices, new types of devices come, and you have to be aware of how to use them. So the training courses are available, yes.
All right. So, um, all these range of contraceptives. So, how effective are these contraceptives? So, which one is the most effective, and for how long do you think that these contraceptives should be used when we're talking about the oral ones or the injections and also about intrauterine contraceptive devices? So, how effective are these, number one, and how long is it safe for the patient to use it?
Okay. One thing you have to tell the patient that this family planning treatment, none of them are 100%,
Mhm.
except the sterilization, which is a permanent method. Okay. So the tablets, injectables, implants, devices, IUDs they can be effective. Okay, we'll start with tablets. Tablets can be 99% effective, provided they
Mhm.
are taken as advised.
Okay.
But if you do not follow the advice, the effectiveness reduces and the chance of pregnancy increases. Okay. So
So
the tablet,
sorry to interrupt. By that you mean that if I taking them at the same time daily, that's what you're
yeah,
saying?
yeah,
Okay.
exactly. So the tablets are 99% effective, provided they are taken as advised. So
Okay.
any disruption will reduce the effectiveness.
Okay.
Okay. So that's why we talk about using extra precaution if you've missed the pill or the emergency contraception comes in. That's for that reason. Implants are there for 5 years, so you just need a local anesthetic, a tiny nick in the skin, and it's inserted. It's the size of a matchstick,
Mm-hmm.
and it releases the progesterone, one of the progesterone hormones, and then you're covered for 5 years. Once you remove it, it's a reversible form of long-acting contraceptive. The IUCDs in Pakistan are available in the form of copper devices or the Mirena coil, and they last for 5 to 10 years. It says which product is which duration.
Mm-hmm.
So, for instance, the safe load is one of the type of the intrauterine contraceptive device which contains copper.
Mm-hmm.
And it's there for 10 years. It gives you the protection. Once again, if you remove the IUCD, your fertility comes back. And if you're planning a pregnancy, you can do that. So these are all reversible methods. Yeah.
All right. What are the contraceptives for men? So you talk about barrier method, and you talk about vasectomy also. Are there any other contraceptive measures for men, and how safe they are?
Okay. Condoms are the most commonly used, and vasectomy is another type. Um, there are no other like implants or injections, unfortunately, available for men at the moment. Maybe in future we come across something. But in females, obviously, you have to the way these act basically they are affecting the periods or the one of the phases of the menstrual cycle and blocking um, the fertilization process. So I think that's why the options are more available for women compared to men.
So in general, what you're saying is that for the men, there are two types of contraceptives, and they don't have any hormones or external stuff
No.
going in there. So that's their contraceptives for men. They're safer, perhaps, if I'm having it right, compared to the women who have to, then have additional hormones and all these implants, copper IUCDs, etc. Right?
That's right. Yeah. Yeah.
All right. So coming back to the contraceptives, so we were talking also about emergency contraceptives. So what are emergency contraceptives?
Okay. Emergency contraceptives are offered when a couple has had an unprotected sexual intercourse, and unprotected, I mean, they haven't used any form of contraceptive device, including a barrier device like a condom. And the emergency contraception used to be called in the past postcoital contraception or morning after pill. But now we are sticking to the term emergency contraception.
Mhm,
A number of pregnancies are unplanned. Worldwide, about 40% of all pregnancies are unplanned,
mhm.
and 60% of them end up in abortion. So, in order to prevent that pathway, the having an unplanned pregnancy and having an abortion, the emergency contraception is used.
And so the emergency, there are some, these are specific for women, and they're also hormonal, right?
That's correct. So, in general, there are broadly two types, tablets and then an intrauterine device. In the tablets, we see two different types. One is called a levonorgestrel only contraception, which is an emergency contraception, which you can take within the 72-hour period or 3-day period. It is a progesterone containing contraceptive. The other one is called Ella-1. It contains a content called ulipristal acetate. The advantage is you can take it up to 120 hours or 5 days. But
Mhm.
again, the earlier you take the emergency contraception, the more effective it is. You
Okay.
can still take it after day 3 or day 5,
Mhm.
but effectiveness reduces. Or say, if a woman starts having vomiting 3 hours after having the emergency contraceptive, then you have to advise her that she needs another pill. So it's better to give her 2 pills in case she vomits. And then you have got an intrauterine contraceptive device, which can be inserted, and it can be used as a long-term contraception for, say, 5 years.
Okay. And these emergency contraceptives are um, available, freely available, right?
Yeah, MKIT brand, which is an emergency contraception, or levonorgestrel tablet, is easily available. There's only one capsule in the pack, so you just take that capsule as soon as uh, after the unprotected intercourse in order to have the protection. Yeah.
Okay, that's good to know. The final question is that who are the women or or families that you will refer for permanent contraceptives? So, meaning vasectomy or tubal ligation. So, who are those people that you would refer for permanent contraceptives? Um, yeah.
Okay. Those couple who believe that they have completed the family, they are somebody who would want a permanent method, because again, you have to counsel them and tell them that, look, in some centers may offer a reversal, but consider most of the time that this will be a one-way process. So have a think about it, what your circumstances are, and how. In families or couples that have got a medical condition running in the family, for instance, a genetic disorder, and they've got already more than one child with a genetic disorder, and they do not wish to have more, they can be referred. Um, and certain women particularly, if they have developed certain condition, a medical condition, or they have got a number of C-sections in the past, and they want to, um, for the sake of the health and their own wellness, they want to have a permanent method of contraception, then they can go for tubal ligation at the time of the C-section when they are having it. So these are some of the cases that I would suggest as a general practitioner to refer. Yeah.
So, is age a factor? The younger you are or older you are, is age also a factor?
For permanent method,
Yes, for permanent contraception.
Obviously, people after a certain age, for instance, somebody who's the average age of menopause is 51 in
Mm-hmm.
the world. So most of the females, obviously, when they are during their reproductive years, they want to go for the tubal ligation because obviously they do not wish to conceive.
Mm-hmm.
So age in the sense is not, younger females wouldn't want uh, a sterilization, put it that way. It's probably those who have completed the families or are towards the menopausal age, they would go for it. Um, it's a very quick procedure. It can be done under, you do not need a general anesthetic for it. The type of anesthesia can be discussed with your surgeon, and it's a safe procedure, and it can be done considering if you do not have medical conditions that are stopping you from having a certain type of surgery or anesthesia. Yeah.
But why don't men opt for it? And we've been talking about,
Okay.
tubal. So why doesn't, you know, why don't men are advise the permanent contraception?
I think we probably need to increase the counseling to men as well.
Mm-hmm.
Uh, Most of the places where I've been in my experience, I've experienced that if there is a population of 100 people, for sterilization or any other method of contraception, 70% or 75 would be females, and 25 to 30 would be men. So there is a disparity, obviously. We need to increase the figures. Probably we need to convince men more towards the permanent methods and address all the myths that are associated with it. Probably men feel that they will lose the sex drive or the libido because of it, or any other concerns that they have. So probably it's the education, counseling. But in the recent session, I have been told that there are studies on the family planning options, which are specifically for the males. So maybe there is a trend towards increasing the uptake in the men as well.
Yeah, I mean, I'm just curious because you also work in UK and you work in Pakistan also. So I was
Yeah.
just curious that whether men there are more inclined to do vasectomy, and men in South Asia are, because of our cultural
Yeah.
ideas, because of our
Yeah.
cultural backgrounds. Yeah,
But I think it has got to do more with the awareness and addressing the misconceptions as well.
yeah.
Yeah.
All right, that was quite a good discussion, Dr. Hina. Anything else you want to add?
I would just like to say that focus on, well, the take-home points would be any method of contraception, particularly pills, is effective 99% if you take it correctly. Um, Condoms do protect against sexually transmitted diseases, so I would encourage its use. And be safe when prescribing, to all the general practitioners, be safe when prescribing pills or any other methods. Do go through the checklist and ensure you're doing the right thing by giving the medication to the patient. Thank you.
Thank you very much. That was quite useful. I learned a lot. And for the viewers, we are going to post this on our YouTube channel and as well as podcast. So we will be talking about another topic pretty soon. And in a few months, we will have a list of the topics that Dr. Hina and I will discuss. And for until then, thank you very much. Bye.
Thank you. Bye.